Well, good morning, all. By my watch, which is to say my phone, which is accurate, my watch runs fast so that I'm not late. So by my watch, it's 9 o'clock. So welcome to Tuesday and the first full day of BAUS proper. And to the endourology, the first of the endourology series that we're going to have during the course of the meeting. So we've got a panel whom I shall introduce in a moment, co-chair Richard Napier-Hemi, and we're going to talk about the management of the obstructed infected kidney. So the team, I'm still keeping my eyes out for Ros Ahmed, who's an interventional radiologist from Leicester, who sits on our committee, who's going to talk about diagnosis and nephrostomy drainage. But I guess it's somewhat like real life that the urologist gets to the patient first, and then the interventional radiologist is involved second. So we may actually kick off with Jake Patterson from Sheffield, who's going to talk about retrograde drainage and timeframes. We then move on to Bruce McRae, a little bit of the soft connection, the soft south connection here. Bruce is our microbiologist at UCH, sits in our Stone meetings, and we've learned a lot from him, and hopefully you will this morning too. Followed by Mervyn Singer, who's intensivist at UCH, who's going to give us some of the basic science of sepsis, very much a hot topic, not just in terms of the patient's temperature. And then these slides I should have had adjusted because Mashesh Nirmalan can't be here, but gloriously we've got Anthony Wilson, also from Manchester, an intensivist and anaesthetist, who's going to talk about the ITU management of the patient when they get there. So that is the team, and then on to the scene that'll be set by Richard, and then straight into the talks.
Good morning, all. I'm going to divert a little bit before we set the scene, and just a little bit of advertising. Please, for the BAUS section of endourology meeting in Oxford, there is a video, tips of the trade session. We would like as many people to put in their little videos. Details available on the BAUS website, and again, it will count as a presentation. So please encourage your trainees, get these tips of the trades in, please. So interestingly, my week on call starts on a Monday, and both of these patients came in same day. I saw them on the Tuesday, and these are fairly typical kind of patients, really. They've both got upper ureteric left-sided stones. They're not quite in the same bay, adjacent to each other. Both of them well on the first day. Saw them on the post-take round, decided we would operate on them on the day after. And these are the kind of patients, really, that we have needed help from all of our panel and their colleagues. So patient one, he's on the day of surgery, his early warning scores go up, and he ended up occupying about 5 hours of the operating list for a procedure that took me around about 5 minutes. It's possibly the quickest stent I've ever put up, but he then became very brittle and unstable, and then spent a little time on ITU. Patient two should have been on that theatre list and got delayed. Overnight, his early warning scores went up, and we put him on a theatre list, and also contacted the interventional radiologist. And in actual fact, the radiologist beat us to it that day, and he ended up with a nephrostomy. They've then subsequently both gone on to have operations. Patient two is stone-free now. Patient one, my stent beautifully pushed the stone up into his kidney, and I can't find it with a flexible ureteroscope. So these are the kind of people that our panel are going to talk about, if that's okay. I'm going to ask Jake Patterson to come up first and talk to you a little bit about the stent options. Thank you, Jake.
So thank you very much. I was hoping that the interventional radiologist might have gone first, so I can keep referencing to as Rosamina has already said. So I might make passing comments to what might be discussed in the future. We've all come across patients like this. Sorry, these are my conflicts of interest. What I'm hoping to cover today is when do we need to intervene? What do we need to do? And what can we find out from the radiologist? What can they tell us that might help us make our decision one way or the other? Why should we put stents in, not nephrostomies? And there are certainly some circumstances when we shouldn't, and we should be putting nephrostomies in, not stents, and I'll touch on those. And also, in light of recent reports, how can we get it right, if not first time, at least more often? So as we've seen patients like this, similar case just presented, left side upper ureteric stone, a bit of inflammatory stranding around the kidney. You get a phone call when you're on call saying that the SEPSIS 6 bundle has been initiated, and we'll hear a lot more about this later on. The patient's early warning scores are going off and they've escalated it for senior review, and we've got a decision to make. So when do we need to intervene? Well, there's loads of guidelines that we work to. BAUS guidelines suggest patients with obstructing stones and infection should be decompressed within 12 hours and some patients earlier. The EAU guidelines suggest early decompression, prompt decompression, but don't specify a time frame. Neither guideline stipulates which method of drainage is best, and the EAU guidelines comment on all the evidence that's been appraised. And obviously there is no good evidence that says one is better than the other, but they do comment in EAU that there's no harm from stenting. SEPSIS guidelines, in light of the NICE guidance that was released in 2016 following the updates to the Surviving Sepsis campaign, talk about how we manage the patients, talk about antibiotic management, early surgical drainage and so on. And there will be local guidelines that we will follow as well. But there are also some very pragmatic local constraints, and the GIRF report has certainly told us some of these. If you look at the England average, this is all for all stones, not obviously infected systems, but there's a high percentage of stents put in a lot of these acute patients. There's another unit, there's an exemplar underneath, which is a slightly different way of doing things, very few stents and more reliance on nephrostomies. And these differences may be accounted for by local practice, local prevalences. It may be a small regional unit has limited access to interventional radiology, and they may be more likely to stent the patients. Busy teaching units might have more ready access to interventional radiology, but may also have more competition for emergency theatre lists. And these are the sort of reality struggles that we face all the time. So what do we need to know? So we need the radiologist to tell us ideally what is causing obstruction, where is it, what's above the obstruction, what's below it, and what about the other side. And what we need to know clinically is various different patient factors. So if it's a stone, we're all familiar with CT scanning. We can get some information about the stone, how big it is, how many there are, if the stone's on both sides. We get some information about the soft tissue. This slice from a CT shows quite a lot of thickening of the ureter around the CT. And there are some metrics reported in the literature about degrees of impaction related to this. And these sorts of pictures, when you see a large amount of friable mucosa around a stone, might make stenting more challenging. What about tumours? Well, people with acute urothelial tumours can present with obstruction and infection. That can be in the bladder or in the ureter. And what about extrinsic compression? That can be either from masses such as retroperitoneal fibrosis or even pregnancy. And obviously pregnancy could be extrinsic compression, could be stones, and the imaging of the pregnant patient is more of a challenge. Trauma is usually fairly obvious because there's a good history of something traumatic happening, so you can usually get that from a clinical idea. But it can present late, particularly post-surgical damage to the ureter. And what about where the obstruction is? We all know stones and other obstructing lesions at various different sites in the ureter can be managed differently. This is a stone that's very, very distal. As you can see, the scan's been done prone to try and delineate where the obstruction is, and it's still clearly within the distal ureter. And finally, bilateral obstruction presenting with acute sepsis is rare. There may be cases where unilateral obstruction is present, but incipient obstruction is present on the other side. You may think about decompressing both sides or just one. It's really important to know if the kidneys are normal. Is the kidney in a normal site? Is it normal anatomically? Is it a transplant kidney? Is it grossly atrophic? Has there been a long-standing obstruction? This is new sepsis. What about dilatation and extravasation? We all know lots of acute obstructions don't dilate, and dilatation and obstruction are not synonymous. And with significant extravasation, you can end up with a lot of infected urine outside the kidney, and that's certainly something which we have to be concerned about. The presence of gas is a serious alert, And emphysematous pyelonephritis may be a rare indication for an acute nephrectomy rather than anything else, but a lot of these patients that are extremely unwell may need temporising with a stent or a nephrostomy. And most importantly of all, perhaps, is there another kidney? So if this is the only kidney, you might be dealing with acute kidney injury, renal failure and urea, as well as all the other complications of sepsis. It's nice to know if there's anything going on below it. If we're going to be approaching the patient in a retrograde fashion, we need to know what the access is going to be like. Have they had a diversion? Has their bladder been reconstructed? Do they have neuropathic bladder that might make finding the ureters more challenging? Is there involvement of the bladder base by any other disease process or a large prostate? You might find it's a serious struggle if you're in an emergency theatre where the staff aren't used to putting stents in or doing anything endourological when you're struggling with angled catheters, slippery wires, fishhook ureters and difficulties getting in with a patient that's deteriorating in front of everyone's eyes. And what if they're known to have strictures or significant BPH that might make access difficult? And again, pregnancy rears its head here. If you've got a pregnant patient, they need managing in a very different way. And certainly, we know that if you've got very distorted ureteric anatomy, and certainly in the later stages of pregnancy, very much longer stents may be required. And if you have fixed-length stents, you may not have anything long enough to get into the kidney. So why should we put stents in? Well, fundamentally, we know they're no different to nephrostomies. The outcomes are exactly the same. And as endourologists, if we're dealing with stones, for example, we know that stents make management of the stone at a later date much more straightforward. You're much less likely to have failed access for a primary ureteroscopy if you've got a stent in. We like being in control as urologists and surgeons, and certainly if you're in charge of the emergency list, it's your patient, you're stenting them, you're entirely in control of that. You're not at the behest of any other specialties. But there are certainly other clinical conditions where stents are certainly a better option. Anticoagulated patients, it's hard to reverse anticoagulation in some patients, and that can make nephrostomy more challenging. Patients with very significant obesity or other anatomical constraints, such as kyphoscoliosis, where the kidney is inaccessible, you may think would be better served by a stent. And also the very combative, confused, delirious patient may be better managed under an anaesthetic than on a narrow interventional radiology bed. I think there are some circumstances where nephrostomy is better, and we know that stents don't drain very well in cases with extrinsic compression, so it may be better to nephrostomize these patients. And again, patients where you're going to be challenging to get into the lower ureter. Very large distal stones can certainly make this a challenge. And if you've got a significantly septic patient who's genuinely not fit to leave the ITU, which is rare but does occur, then I think that's something to bear in mind. And again, if retrograde access is going to be impossible, then obviously a stent would be preferred. Sorry, a nephrostomy would be preferred. As Richard alluded to, patients can deteriorate after they've been stented, and the phenomena of the septic shower is quite well described. Up to 6% of patients on top of those already heading for ITU will go to ITU after they've been stented. And there are certainly cases of particularly junior trainees putting stents in that aren't in the right place, and inexperienced surgeons with sick patients in an inexperienced theatre is not necessarily the right combination for these patients. Failed stenting is reported very variably in the literature, but certainly between 1% and 7% in the series that I could find. And a lot of this is about points of technique and a lack of appreciation of how to do this. So when you're in the emergency theatre, it's recommended, particularly with stones, to take care near the obstructing lesion to make sure you don't perforate friable mucosa, use hydrophilic wires, put a ureteric catheter past the obstruction and drain some infected urine out as much as you can, not only to send specimens to microbiology for prompt assessment of what bugs we're dealing with, but also to decompress the system and take the pressure out of it. And then it also allows you to have space for a gentle retrograde, perhaps to make sure you're in the right place before you put an adequately lengthed stent in. We know that stents can cause problems. If you leave them in for too long, they'll become colonised, and there's an increased risk of sepsis with future stone treatment. And stent symptoms is the bane of our patients' lives that we all know about. So I think in summary, early drainage is key. Stents are ideal for the majority of our patients, although there are certainly some exceptions. It's important to have adequate high-level support, and we'll come across the ITU management of these patients in due course, but it's certainly important not to defer things for too long. Thanks very much.
Jake, thank you. So we can bring up the slides now for Ros Ahmed and welcome our interventional uroradiologist to the floor to tell us about nephrostomy drainage.
I'd like to thank the committee for inviting me to talk to you today about radiology, my role and what it adds. So the overview, I'll discuss how radiology is involved in diagnosis and nephrostomy insertion, patient preparation, and I'll show some images throughout the 10 minutes. So as we all know, prompt diagnosis and decompression is important. Potentially it's a reversible cause of kidney injury, and also these patients progress rapidly. In several case series, about 85% of patients with urinary-related sepsis in ITU had urinary tract obstruction, and the vast majority of these had ureteric calculi. There is significant mortality related to these with these patients with septic shock, with series quoting between 30 to 50% mortality. So regarding the imaging diagnosis, ultrasound is first line, it's readily available, and it has a high negative predictive value for ruling out obstruction if there's no hydronephrosis on the scan. It is important to bear in mind it also has a high false positive for mild hydronephrosis in the absence of obstruction. And examples of this are diuresis of pregnancy. It's not uncommon to get a little bit of a mild hydronephrosis which is unchanged on serial scans in renal transplants, and sometimes when stents are in situ. And low-dose CT-KUB is the test of choice for urinary tract calculi. And as my colleague pointed out, the level of obstruction will help you elude what the underlying problem is. So intrinsic lesions occur more commonly in the kidney. The ureters are prone to extrinsic obstruction from tumour or RPF. And whether the obstruction is unilateral or bilateral obstruction, we may think of a pelvic pathology such as gynecological malignancy or bladder-related problems. So this is a case from work with a patient with a gross hydronephrosis, and she's had a pelvic ultrasound. I'll just see if the pointer's working. So this is the pelvic ultrasound, and there's a mass here, and this was actually related to the left adnexus. So she had endometrioma, but also deep pelvic endometriosis involving the bladder and rectum. And she actually, our urologists wanted her to have a nephrostomy first before the definitive treatment of the endometriosis and bladder. Hydronephrosis can also occur without obstruction, as I've suggested. So vesico-ureteric reflux, diuresis of pregnancy, occasionally in transplants, and the dilemma of the extrarenal pelvis versus PUJ obstruction, which is difficult just to diagnose on anatomical information, usually requires the MAG3 exam as well. This is another case from my practice where we've put a nephrostomy into a young woman presenting with pyelonephritis symptoms and flank pain. The nephrostogram after the event, the acute event, showed extrarenal pelvis, and there was drainage down the ureter quite briskly, and this was confirmed by several MAG3s where there's good clearance from both kidneys. Just wanted to touch on pregnancy from the radiologist perspective. So clearly in this case, I don't think there would be any argument about putting a nephrostomy in. Patient was septic, she's got gross hydronephrosis, possibly some cortical thinning. But as we all know, a lot of the cases aren't that straightforward. And that's because of, this is the gravid uterus compressing the renal vein and the IVC. And after 20 weeks gestation, there's significant IVC compression, which decreases maternal cardiac output by up to 30%. And it is normal to get this physiological hydronephrosis and gonadal vein dilatation. This is the same patient, just to show the level of hydronephrosis, which is physiological. But interestingly, urinary tract stones in pregnancy are not that uncommon. They're the most common painful non-obstetric condition for hospitalisation, and they often have an incorrect diagnosis, up to 28%. Most of them pass spontaneously, but delay in treatment can lead to complications related to premature labour, etc., and sepsis. So it's important to bear in mind. So one of the ways in radiology where we try to help differentiate physiological diuresis from obstruction is with Doppler. So we look for the ureteric jets because you're getting the flow of urine into the bladder. The Doppler will detect that, so absence of the jet, but also the resistive index, which is a non-specific marker of resistance of blood flow into the kidney. But if you have unilateral obstruction, you'd expect the resistive index to be elevated on the side of the obstruction, so above approximately 0.7. So it's useful to use the ultrasound and the additional Doppler in these patients. MR can be useful. The problem is, as I've explained, with the patient lying flat and the procedure taking at least 30 minutes, it's quite difficult to tolerate. So it's difficult to get a technically good study, although it is a good option in experienced hands compared to doing a CT, which has the radiation burden. So obstruction without hydronephrosis, this can occur early in urinary tract obstruction, can occur with retroperitoneal fibrosis. One thing I would ask you to do is to consider stenting if there is no hydronephrosis. A lot of these patients present out of hours, and there is a higher complication rate related to nephrostomy out of hours, related to the sickness of the patient and variability of operators and also skeleton service. So with a non-dilated system, it's likely there'll be a higher number of passes and the risk of pseudoaneurysm and hemorrhage is increased. So this is from Quality Improvement Guidelines for PCNL from Society of Interventional Radiology. So you can see with the obstructed system without stones, nephrostomy has a very good success rate of 90%, and also in transplant, but in the non-dilated system, this goes down. And interestingly, if there are partial or complete staghorn calculi in the kidney, the success rate of nephrostomy goes down as well. And this is in the context of non-infected patients, so it'd probably be worse for the non-obstructed in sepsis. So radiology's phoned and you want a nephrostomy now. So we've established the diagnosis both with imaging and clinical. So the next most important thing is to look at the local resources. Now, there is a balance between a delay in decompression and putting a stent in, I think. So if it involves a hospital transfer and the patient's sick, it probably is worth considering stenting because of the delay in treatment would have a worse outcome for the patient. Also, interestingly, when I've looked at the data, not only is out-of-hours nephrostomy increased complications, the risk of septic shock is 7 to 9% in those in pyonephrosis, which is similar to the ones that having ureteric stents, surprisingly. So anaesthetic support needs to be on standby. So what we'd like before we do the nephrostomy is the consent done according to your local trust policy. And if the patient is unable to consent, we'll need a consent for, and often, I mean, I think this is a legal requirement. It needs to be done by the clinician looking after the patient. We will need a coagulation profile. And actually, the evidence base for this is not hugely robust, but there is a link between platelet counts below 100 and risk of bleeding. So the platelet count is very important. Radiology will have resuscitation facilities, but we will need anaesthetic and medical support because often these out-of-hours nephrostomies are done with the skeleton service. So there'll be a nurse, a radiographer, and the operator. So the sedation aspect is managed by a nurse on her own. Right, so I'm going to try and get this to work. So this is a young female transplant patient. She had a difficult JJ stent removal, and she had a sudden drop in her GFR. So it's going to go quite quickly, but I'll try and work through it. So we have her transplant nephrostomy here, nephrostomy kidney there, ureter, and you can see these almost a Steinstrasse in the lower ureter VUJ. And what we think happened was when they removed the stent, the encrustations got displaced into the urinary tract, and that caused an acute obstruction. She's a very reasonable patient, attended with her mother, and was quite happy and compliant, however, became very agitated in the room. We're not able to restrain patients, it's battery, and the resource limitations are that we often do need assistance from urology. And I don't know if an anaesthetist is here today, but it's important to, deep conscious sedation in itself has risks compared to general anaesthetic. So often we get to a point where the airway may be compromised with the deep conscious sedation. So why do we need the clotting? There's no direct visualization of and control of bleeding compared with open surgery. A lot of these patients have chronic kidney disease or uremia. Platelets are not functioning correctly. They may be on anticoagulants. They may be in DIC. So that's why we ask for correction of the clotting parameters. And with DIC, it's important to decide and make a judgment whether the clotting is correctable. You may get to a point where the decompression is delayed so much and the clotting is not correctable for percutaneous nephrostomy. So we need a cooperative patient who's able to lie down or on their side. They can provide consent or the consent process has been done. The patient has choice and alternatives have been discussed. I mean, that's important because the number of patients, I appreciate it's an emergency situation, but the number of patients that ask, why am I having this? How long is it going to be there? And what's the plan when they come down to radiology is huge. So just that communication, even if you don't know the answer, can provide them with a lot of reassurance. It's interesting, my colleague said the VUJ calculus, the large calculus consider nephrostomy, because from the radiology side, we always think that they should have a stent, but I appreciate it could be impacted. So just looking at coagulation, these are the CIRSE, which is a big European radiology interventional society that we're part of. And they did come up with some guidelines for coagulation. But unfortunately, they said that the experts expressed opinion that severe coagulopathies and severe low platelets should be corrected, but they're not able to give thresholds. And in their risk of procedures, it's interesting, you know, the routine nephrostomy is actually up there with the procedures with significant bleeding risk, difficult to detect or control. So it's up there with all the biliary, vascular, tips, etc. And also just to point out that in the setting of pyonephrosis, the septic shock reported rate is 7 to 9%. The other main complications are bleeding and transgression of adjacent structures such as pleura or bowel, which is very rare. So in conclusion, it's an effective and relatively safe procedure. However, for a successful outcome, consider the local resources and avoid delays, patient preparation including clotting, and set up for additional medical support or ITU bed as required. And also consider the patient factors, whether they are going to comply and they're not delirious and uncooperative, because that can't be managed with the conscious sedation. Thank you.
We're going to welcome Bruce to the stage now to talk about the microbiological side of things. Grateful for the 3 people so far have put questions in via the app. We'll come to those at the end of the session if that's okay. But please do put your questions in.
Good morning, everyone. Funny to find a microbiologist in a urology meeting. I'm quickly going to review I suppose what can a microbiologist contribute to the two scenarios that have been set? What kind of specimens should be sent? What are the organisms involved? And then trying to think about how does one make a decision in terms of empiric therapy, what empiric therapy to use. And then a little bit of a discussion about review in the sort of antimicrobial stewardship. If I go to parties and I'm feeling that people start asking me what I do, and I want to stop the conversation very quickly, I just say, give me a secretion and I give you a bug. And what I'm going to show you here is, if you look at my slide, I mean, we've already discussed the role of full blood count, UNE, and with CRP, or they've already been given to us. I mean, microbiologists exist in terms of the specimens we get. And I mean, the classic one in this kind of scenario would be a blood culture, or maybe more than one blood culture, partly because once after the procedure, the patient often looks quite inflammatory and has high fever, etc. And so people would contemplate getting a second blood culture. And then urine culture, be that an ordinary MSU. But importantly, urine from the time of uteroscopy or else from the time of nephrostomy. And those are very important specimens, and the really important thing, and when I was given a brief for this, it was almost like, please, tell people what to write onto the request form, just not sort of a simple, stone patient or on the request form. And the importance is because if we get that information, we change the processing in the laboratory. So actually we use more urine. We put more urine on the agar plates. And actually we change, we look, these are done as sterile procedures, and therefore we follow up all the organisms that we see. And then the other important thing that we do at UCLH is that we culture the stones, which actually give us information. Sometimes if you have to go back again, actually is important what organisms have previously got right up into the kidney. So in terms of the organisms are this, in the period of time that I've been working with the Stones team at UCLH, I've seen a wide range of organisms. And in fact, keep on getting surprised in terms of what we find in the kidney. But the common organisms are sort of E. coli still is the sort of top, and Proteus mirabilis, two organisms that have, it's within their chromosomes, etc., that actually they fine-tuned to cause problems within the kidney. Other organisms that sometimes cause problems, Pseudomonas aeruginosa, and I've put it in here partly because sometimes the empiric therapy we use doesn't naturally cover Pseudomonas aeruginosa unless you're using an aminoglycoside. Someone mentioned early on emphysematous pyelonephritis, or changes in the kidney, where often one thinks of Klebsiella. So all those organisms are gram-negatives, and occasionally there's some gram-positive organisms, I think Enterococcus, and occasionally we've seen Candida. So in terms of empiric treatment, I think as a microbiologist, I need clues in terms of in trying to design empiric treatment courses. And one of it is, if I then do I change things in view of the patient? So taking the relevant history, importantly, does the patient have any allergies? Looking at renal function in terms of one's not going to use aminoglycosides if the patient has lost a significant amount of renal function. Important is the previous urological history. And as I've alluded to previously, previous cultures, i.e. stone culture, urine culture, cultures from other sites help me in, do I have to modify the empiric treatment? Importantly is the issue of antibiotic resistance. And certainly at UCLH, we see patients who are referred from all over, and increasingly I take cognizance of travel and specifically people who've been hospitalized outside the UK. I just want to point, in terms of your organism, E. coli, if you look at your organism and look, this is invasive E. coli isolates with resistance to the carbapenem, so your meropenem, your imipenem, ertapenem. and this is from 2016. It was published just the other day. You'll see that actually for E. coli, actually everything looks okay. But if you look at Klebsiella, you can see that certainly in Greece, Italy, Balkans, there's a significant amount of resistance. Now, the concern is actually that we'll start seeing this resistance in other organisms, including sort of E. coli. And a lot of the movement in terms of government policy is actually is because of what we are seeing here on this map of Europe. So in terms of talking about the empiric treatment, I'm not going to make any specific kind of suggestions here today, but I mean, one has a range of amino glycosides. I mean, the trust I work in, we use gentamicin, but increasingly we have to monitor the gentamicin resistance. And sometimes it's really disappointing to see that patients are given gentamicin when they're septic, and when you have a look, they've recently had a urine in which actually you had a gentamicin-resistant organism. I mean, stock standards are still cephalosporins, so things like cefuroxime, ceftriaxone. In a trust up the road, they use temacillin, which is a penicillin, and they use temacillin partly because they are concerned about the extended spectrum beta-lactamases. Still a role for ciprofloxacin. I've put here the restricted antimicrobials because sometimes if I identify a patient who's got significant risks in terms of having a multi-resistant organism, I need to draw on other antimicrobials. So, I mean, the safest one would be meropenem, but in my recent the one I rely on is impiptazo. But in my recent practice, I've had to rely on colistin for a multi-drug resistant organism, as well as fosfomycin. And, both of those agents, I've used quite a lot of colistin in my microbiological practice. Fosfomycin, I've used a lot of oral fosfomycin, but in terms of IV fosfomycin, my use is increasing. So what kind of information can we give you? And I think there have been some changes here. I thought I'd run these through in terms of urine and separate them in urine and blood cultures. And when can we start giving you information? I think on day 0, there's some clues in the urine microscopy, and obviously the urine culture starts. On day 1, because of the use of mass spectrometry, this is something, I suppose, in the microbiology world, we just call it the MALDI. We can often give the name of an organism on day 1. And within the name is actually, a microbiologist can certainly make decisions, often on the name of the organism. But one still has to wait for day 2 for the antimicrobial susceptibilities and resistances to come back. In terms of blood cultures, if you take a blood culture, most blood cultures in this setting will be positive on day 1. And within the laboratory that I work in, but not in all laboratories, then also now ways of actually doing the identification on that particular day. So again, using the MALDI process, we have the name of the organism, I think, 1 day earlier than people were generally used to in the past. And obviously, if the blood culture is positive on day 1, hopefully on day 2 we should have some susceptibilities, including resistances, to inform decision-making. The important thing is that what you do with all your patients is a sort of daily review. But I think the important thing to be aware of, and there's a lot on this, and is the whole issue about IV to oral switches. So significant that the Department of Health has set significant targets for hospitals, and there's going to involve much more for the consultants and at the time of review in terms of can the patient, there's a series of questions that there's a sequence, so trusts get top sliced and essentially a part of their budget, and they get it back if they're compliant with the various targets that people set. And one of the targets is review and a query IV to oral switch at 48 to 72 hours. They're also kind of restricting the use of piptazobactam and meropenem. And in 2018, the targets now increased. It's really important, moving hospitals to narrow spectrum antibiotics. So there's quite a lot of pressure in terms of actually what I suppose, what happens to the patients subsequent to them having an infection. I think I've touched on the impact of resistance, but a lot of my decisions now, at the time when one goes from IV to oral, is I'm looking at the isolates that we have got in the laboratory and then using the resistant pattern to inform what we use orally. And then the really important thing is determine the length of treatment. And you know, the microbiologist would work with you. I did a ward round yesterday before heading up here on the train yesterday, and it was just a sort of continual, well, you know, this, certainly with junior doctors, has been drilled in terms of they need to supply, you know, everything, question, virtually every doctor was asking me, because there were very few urologists on the ward, was saying, you know, how long do I need to treat for and continue? But all these things are being tightly monitored. And the challenges are, if we want to save the antibiotics that we currently have, we have to use them judiciously at the current time. Thank you very much.
Bruce, thank you. As Mervyn Singer comes up to give us some science, I'll just draw your attention, because you may have missed it, the microbiologist on the wards doing a ward round. What a fantastic example of collaborative and integrated teamwork. So with that, Mervyn, tell us about the basic science.
Darren, Richard, thank you very much. Good morning, ladies and gentlemen. 10 minutes on what is sepsis. Okay, what is it? Well, I'll tell you what it is and what, importantly, it isn't. This brilliant article on BAUS, so conflict of interest declared, came out 2 years ago, and this says what is sepsis, and the definition is life-threatening organ dysfunction caused by a dysregulated host response to infection. The two crucial points I want to flag up: it's not the infection, it's how the patient responds to the infection. So the emphasis has shifted from the trigger, the infection, much more towards how the host deals or doesn't deal with it. And that dysregulation leads on to organ dysfunction that can end up potentially killing the patient. So there's been a sort of, perhaps not so subtle shift in emphasis. So this much bandied about term, urosepsis. Because one of the problems, and that's why the definitions were changed, sepsis meant different things to different people, and as a result, the incidence and mortality rates were hugely variable because people chose to call it what they wished. And so this is bandied around a lot, so now you need to have organ dysfunction. And even the World Health Organization agree. ICD-11, the latest coding system, which will apparently be with us for the next 20 years, has just come out, and you can see they've adopted the new definition. So you need to have organ dysfunction to call the patient septic. So huge numbers of people get infection. Many don't come anywhere near a hospital, let alone an intensive care unit. So the ones that become septic are the bad infection that can end up killing the patient. The bug itself doesn't kill you, it's the host response, leading to the organ dysfunction, leading to the potential risk of dying. And as part of the work on the definitions, we looked at big data, so about 850,000 patients who had cultures taken, antibiotics started, and basically there's this SOFA score, which has been around a long time, and this is it, so you don't need to memorize it, but essentially a change of 2 or more points from the patient's baseline, and many patients have a degree of chronic renal dysfunction, equates to a 10% or above chance of dying, i.e. life-threatening. And so these are things, you don't need to score these at the bedside. You know, you're treating the patient, this is more for the sort of coding, epidemiology, etc. And they use things that are routinely measured in any unwell patient. For septic shock, again, meant different things to different people. So we've tried to tighten up on that, and the definition is you have to have a combination of circulatory, cellular, and metabolic abnormalities associated with a greater risk of mortality than sepsis alone. And again, going back to big data, you needed this combination. So after the patient's been adequately volume resuscitated, you're needing vasopressors to keep the mean arterial pressure 65 or above, and the lactate is still persistently high, above 2 millimoles per litre. That equated to about a 45% chance of dying. If you didn't have both, so you could either have organ dysfunction with vasopressor requirement, organ dysfunction with a high lactate, or organ dysfunction with a normal blood pressure and a normal lactate, your mortality was around 25 to 30%. So that septic shock definition, the criteria, the new criteria, fulfill that greater risk of mortality. So in terms of pathophysiology, once upon a time, you got an insult, infection, trauma, whatever, and that led to a systemic inflammatory response, SIRS, and that led to organ dysfunction, organ failure. And thankfully, we've got rid of SIRS, because SIRS in most people is a completely normal, healthy response. You want a temperature. When you have an infection, you want a white count response. So SIRS means the host is responding. In some people, it's dysregulated. So now we've abandoned that. Yep, you do get inflammation, but organ dysfunction is far more interesting than that. So how do we get from inflammation to organs failing? Very simple question, and people wave their hands in the air and go, oh, mediators. But how do the mediators cause organs to fail? Interesting question. It's like asking an oncologist, how does cancer kill you? And they go, huh? And I said, well, if you understood that, then perhaps we treat patients better. And they go, huh? That's another lecture. Okay, this is something, in fact, 2007, but the principles still hold true. We've become a bit more sophisticated in understanding the pathway. So essentially the bug comes along and it's recognized by us, the host, pathogen recognition factors, and toll-like receptors and things like that you may have heard of, and that triggers an inflammatory response, releasing mediators, cytokines, nitric oxide, yada, 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 and at the same time, we're activating an anti-inflammatory response to quench the flames. So we want some inflammation to deal with the bug, but at the same time, we don't want it to go out of control. So there's an anti-inflammatory response to provide the checks and balances we need. But unfortunately, sometimes for whatever reason, we don't understand why, it goes haywire. You get an exaggerated pro and an exaggerated anti, and that triggers downstream pathways, and the brain's probably quite important. And lots of things are happening. So you get immune dysregulation, coagulation activation, so even though we don't see clinically obvious DIC anymore, you can see it from a laboratory measurements, but thrombin is a very potent pro-inflammatory activator. You get epithelial dysfunction, cardiovascular dysfunction affecting macro and microvasculature. The heart can be significantly depressed in its function, and obviously the vasculature can lose its tone, and you need vasopressors to try and improve the blood pressure. There are many hormonal changes. Some things go up, cortisol, for example, some things go down. Thyroid hormone goes very low. There are many metabolic changes, and my particular love is for the mitochondria. It's my favorite organelle. You'll find out why in a second. So the net result is organ dysfunction. And the organ dysfunction can manifest itself clinically in many, many different ways, or combinations thereof. And again, we don't know why some people get predominantly lung problems, ARDS, and some get predominantly cardiovascular. Some people get renal failure, some people don't. We don't understand why. The interesting thing, which I find intriguing, is that these organs have failed, but they look remarkably normal. This was a very nice study from Richard Hotchkiss. It was reviewed in a New England Journal paper. But essentially, they did multiple organ biopsies soon after death in 20 patients dying of multi-organ failure. And what did they find? Was essentially the organs look normal. Cell death in heart, kidney, liver, lung, relatively minor, didn't reflect the fact that these patients had organ dysfunction in life. Patients with myocardial depression, Cardiomyocytes look normal. ATN, it's a misnomer. You very rarely see significant amounts of necrotic tubules. You may get the occasional 1 or 2, but that's not enough to explain why these kidneys fail. So you have this interesting paradox of failed organs that look normal, so we've got to then think of another paradigm to explain it. So I would argue all of these things all impact on my little favourite organelle, the mitochondria. So there's a metabolic bioenergetic shutdown, and so the organs essentially hibernate, they go to sleep. So the organs are looking normal, and they've got the propensity to recover if the patient gets through. And so there we are, all the organs are dropping off, boom, into Liverpool.
Not the brain.
Actually, yeah, I won't mention all the haze, it just come up, anyway. Final 2 slides, moving quickly on. The other thing, we're now actually intensive care. One of the triumphs of intensive care is our ability to prolong death. And so, unfortunately, it's true. Whereas people in the past, 20 years ago, were dying quickly of their sepsis, now we're very good at keeping them alive, and they die later on. And yes, yeah, there's another lecture as well. But there's this interesting concept that's increasingly talked about of chronic critical illness. So these patients get through their early acute illness, and then they go into this state where they're just not improving. They have this persistent inflammation, a high CRP, immunosuppression, which leaves them basically vulnerable to secondary infections, and they're stuck on an ICU bed with tubes in their mouth and various orifices, etc. And so they're prone to secondary infection, and that immune function is compromised, and they're very catabolic, so they don't get the muscle bulk back to get them off the ventilator, get them mobilized, get them out of hospital. And it's an increasing problem, and so now, I think 10% of patients take up about 70%, 60, 70% of ICU bed days. So we're left with this sort of progressive, sort of indolent state that eventually can see the death of the patient. So clearly, it's not just the early stage, the exciting acute stage, but trying to get these chronic patients back on their feet and recovering. And again, there's a lot of interest and work going on in this area. I'll summarize by saying, yes, it's a highly complex syndrome triggered by infection, inflammatory pro and anti, and a whole load of downstream pathways. This concept of hibernation, the organs switch off as a response to being critically ill. But it may actually be an adaptive response, because if the patient gets through it, these organs generally recover and the patient can get back to their previous life. Therapy needs to be more in tune with the body's response. I think the triumphs of critical care has been actually in doing less to the patient. And so outcomes have been improving because of our ability to actually do less, ventilate less hard, feed less hard, give less fluid, etc., and less antibiotic. So it's trying to work with the body rather than against it. And on that note, thank you very much for listening.
Thank you. I'm just going to welcome a colleague of mine, Anthony Wilson, who is going to talk about the critical care management, and I think will add probably to what Mervyn has entertained us with. I particularly hope he's going to answer the question, should the critical care unit be renamed the prolonged death unit? I'm aware that 10 o'clock is AGM. We're probably going to slightly overrun. We're happy to do that because I think this is going to be fascinating, and we have got some very good questions to go through. But if you want to leave and go to the AGM at 10 o'clock, nobody's going to be offended, so do feel free to wander off. Okay, thank you, Anthony.
Thanks, Richard. Good morning. Thanks very much for the opportunity to speak to you here today. I'm a consultant in anaesthesia intensive care at Manchester Royal Infirmary, and I was asked to talk about the ITU management of the infected obstructed kidney. I've got no disclosures to make. Is it just the next button? There we go. Yeah, so the tagline I received for this talk was, "This will tell us what is expected of us all." No pressure then. I think when I thought about this and I reflected on it, in reality, when patients who have obstructed infective kidneys come to ICU, they do so with sepsis. And as we've heard, if they've got septic shock, their mortality is around 40%. And if you compare that with the inpatient hospital mortality following an ST elevation MI, which is around 10%, that tells me that we're dealing with a sick and complex group of patients. So in answer to what's expected of us all, I think it's teamwork. We've already heard about the microbiological advances and the management of the microbiology of the patient, how to decompress the obstructed kidney, and the pathophysiology of sepsis, which leaves me to do the down and dirty. What's left is what helps patients to get better, and how do we achieve this together as a team between ICU and urology. So we've got 26 ICU consultants at MRI. They all use WhatsApp, so I asked them. I wanted to know what it was that they thought was important about looking after the patient with the obstructed infective kidney on ICU. So my talk is now going to be a synthesis of my thoughts and their responses, bearing in mind that the comment immediately before mine on our WhatsApp feed was that they were taking orders at the bar. So I can't really, say how reliable what they've said is going to be, but let's give it a go anyway. I want to share with you a picture of what I think is a good team approach to the care of these patients on ICU. And I think that falls into three categories: the initial treatment, communication while they're being looked after on ICU, and then treatment goals and taking shared responsibility for those as their care progresses. The first category is initial treatment, and I think the first part of that is recognition. And we've heard already from Mervyn that sepsis is life-threatening organ dysfunction secondary to a dysregulated host response to infection. We need the urology team to identify that for us on the ward. And it's hard to mention this knowing that the architect of the Q-SOFA score is in the audience, but the Q-SOFA score is a screening tool that can be used to identify sepsis in patients on the ward. And that's what I'd encourage you to look at. If you have a patient who's got infection and they meet any two of these three criteria, it suggests that they're going to be at risk of a bad outcome. And they're patients who need examination and investigation to look for causes of organ dysfunction, and then early referral to critical care. Speaking of early referral, when patients are sick, we want to know early. This is an observational study that looked at all comers to ICU, not just septic patients, and charted hospital mortality against the time to delay from the first time that they were noted to be critically ill. And I recognise that there's problems with observational studies, but what this highlights to me is that these patients can deteriorate quickly, and an early response is important. And as urologists, I think you should expect a timely response from the intensive care team if we're going to work well together as a team. While you're waiting for that timely response, what should you be doing on the ward? Well, these are the latest 1-hour guidelines from the Surviving Sepsis bundle. And I think an important thing to mention in these guidelines, and the one I want to emphasise, is the administration of intravenous early broad-spectrum antibiotics. There's been a number of different pieces of research that have suggested that early antibiotics reduce mortality, and that delay in antibiotic therapy increases mortality over time with every hour that passes. It should be said that we should be taking blood cultures prior to this, and that if blood cultures are going to delay antibiotic therapy by more than 45 minutes, that's not a good thing. And I'd also like to highlight the advice about fluid resuscitation in this bundle as well. It talks about 30 mils per kilogram of crystalloid infusion. What I'd encourage you to do is I think of that as a checkpoint. A point that if you're reaching the point of giving 30 mils per kilo of crystalloid, somewhere between 2 and 3 litres, and the patient's still hypertensive, that's a sign, in my opinion, that fluid alone isn't going to be the answer. And I think that creates an expectation on the intensive care team. If you've done reasonable attempts at fluid resuscitation on the ward, and the advice from the ICU doc is, well, let's give some more fluid and see how they go, that's not really a substitute for admission to critical care and appropriate initiation of vasopressor therapy, in my opinion. Regarding antibiotics, we've heard that they should be broad-spectrum, guidelines-based, and that previous culture results are important. If someone happened to have a positive urine culture in the past that was resistant, that showed a resistant organism, I think that could be life-saving information. There's evidence that if inappropriate antibiotic therapy is started for sepsis, a septic shock, and we find out that the antibiotics didn't treat the organism that's causing it, that the mortality can increase up to 5-fold. A team approach to source control is also vital, because source control can reduce mortality, and it can also give us more accurate culture results. And the surviving sepsis guidelines would suggest, as I think we mentioned with the urology guidelines, that this should be tried to be achieved within 12 hours. I recognise that there's going to be a balance between intervention and achieving source control and having a patient who's well enough to actually go and have that done. My colleagues recognise that there was a real benefit in having a urologist who can advocate for time in theatre or time in the interventional radiology suite, while the intensive care guys are getting on with packaging up the patient. The general consensus was that you guys are far better at getting access to that time than we are as intensivists. So we really value your role in that regard. The second facet of my picture of good teamwork was communication. And by means of an illustration, this is an example of a fairly typical mid-morning conversation between the ICU consultant and one of the ICU registrars, let's say. Can you recognise any of the usual suspects? The things that commonly come up in our conversations with each other, that take 2 or 3 conversations or chats to sort out and get the right answer for. Why is it that communication is difficult on ICU? Well, I put it to you that it's difficult because ICU is an error-prone environment. This first study was a sort of a review of over 200 ICUs around the world, in which the authors found that the rate of error in the care of patients was around 20%. That meant that 20% of patients who were cared for in ICU had either an error that had the potential to cause harm or actually caused harm during their ICU stay. And the second study, and what were the cause of those errors? Well, the top cause was lines, drains, and catheters, followed closely by medications, which I'd suggest are 2 of the things that we, as surgeons and intensivists, often end up talking about when you come to the ICU. And the second study at the bottom of this page highlight that a lot of these errors are linked to communication. In this paper, the authors looked at 4 months of ICU activity, and they charted everything that was done to the patients. And they found that in 2% of cases, that activity involved doctors and nurses talking to each other. But of all the errors that happened on ICU, 33% of those errors were associated with that 2% of activity. And I want to give you a couple of simulated examples of that. So, number 1 is the emergency antibiotics prescribed for septic shock on the ward. Prescribed, but then a delay in them being given because we forgot to mention and remind the nurses on the ward, who were busy doing umpteen other things, that we'd actually prescribed them and they needed to be given urgently. The second is nephrostomy drain flushes, which are sometimes asked for and written on the post-op note from interventional radiology, and then, without verbal handover, are promptly forgotten and missed by the cycle of repeated ICU shift changes. We've got into the habit of deliberately prescribing these on our drug cards to try and minimise that error from happening. I'm not suggesting that this is a criticism of any particular group of healthcare professionals. It's just a reflection of the fact that when different teams of doctors and nurses talk to each other, and doctors talk to each other, we're prone to making errors, and we need to take steps to mitigate that, particularly on ICU. So what does good communication look like? Well, I put it to you that it starts from shared respects for expertise and recognition that we're engaging in a shared endeavour to make the patient better. And then we need a shared understanding of treatment goals. I think the intensivists need to understand what the urological plan is and what the timescale is for that plan. The urologists need to have an overview of the patient's critical illness and the medical problems that they've picked up along the way. And we all need to understand the nutrition, the rehabilitation aims, and the things that other healthcare professionals are doing for these patients. It's only when we've all got a holistic picture of the patient that we can start to give each other meaningful advice that's useful and leads to good communication. And lastly, I think we need to blend formal communication and the use of the medical hierarchy of different grades of doctors and the bleep system with more informal communication, which research suggests both surgeons and intensivists prefer and think is more effective. When you come to see your patients, we want to hear from you. Come and talk to us, because often you solve some of our problems. If there's going to be big changes, tell us about them, or text us, or phone us, because that's really useful to know, and it works well. As one surgeon in the study at the bottom of this slide put it, if rioters in London can organise themselves via text message in 1 minute, surely we can do better in hospitals. What about treatment goals, which was the last facet of what I thought was a good teamwork in critical care? Well, I think the first thing to say is that some patients, by virtue of frailty or the disease process, well, in their cases, intensive care is probably not indicated. And we would encourage you to make end-of-life decisions for these patients on the ward and to ask us for help if you need it. For the patients that do come to ICU, we sometimes need an MDT approach to the management of their treatment and, if it occurs, to their end of life. When that happens, I think we really value surgeons' input. And this was sort of brought home to me just the other week when I went to a treatment limitation discussion on the ward. I was the intensive care doctor who'd been drafted in to see this patient because they'd become critically ill. And I could talk to the patient and their family about frailty, about physiology, and about the nature of ICU care. But the surgeon, who'd been looking after this patient for 3 months, could talk about trust and could talk about the process of care that the patient had gone through over the last 3 months. It was blindingly obvious to me which was more useful to that family. When we do have these MDT meetings, I think it's important that we have a shared understanding of prognosis. Mervyn mentioned the patients that indolently stay on ICU, and I think there's evidence that different healthcare professionals understand different things by prognosis. Do we mean death? Do we mean living with severe disability? Or do we mean never getting well enough to actually get out of hospital? And I think we need to clarify what that means between us before we have conversations with families. And then we need to have a consensus about the treatment plan or the end-of-life plan, if that's appropriate. And the reason that's important is that families value discussions of prognosis and treatment plans, and they don't mind if that treatment plan is a little bit sketchy or the prognosis is slightly unclear. But what they do find extremely distressing is when one team of doctors and another team of doctors tell them different things. So we need to achieve consensus. So, in summary, I've tried to present what I think is a good team approach to ICU care between urology and critical care. I think a lot of what I've said could apply to other surgical teams, and it could apply to our role with the radiologists and the microbiologists. But basically, I think we need to recognise and treat sepsis and expect a prompt response from ICU to care for these patients. And we need communication that works, that respects our own individual expertise and works on a blend of formal and informal communication. And then we need to take shared responsibility for difficult treatment decisions and end-of-life care. Thanks very much.
Anthony, that was great, and thank you. We've covered an enormous amount in marginally over an hour, and thank you for tying it together so neatly at the end when the patient is actually on ITU. It would seem a sacrilege and entirely wrong to have so many people in the room and such an expert and distinguished panel who've spoken so beautifully this morning, not to ask some of the questions that you've put through the app, which Richard kindly has collated, and we'll then go through those in a theme. So if we can ask the panel to come up and sit at these chairs, just be careful, this ledge is narrow, it's like a precipice at the back, which is why you're sitting there, you've got to look after yourselves. And then Richard will talk us through the questions that you've put to them.
Grateful to everybody who's asked questions, and obviously not going to have time to ask around about 30 questions, but I've summarised a few. So, Ros, could we start with you? Quite a number of people want to know who should consent for nephrostomy, because we're very much taught that the person performing the procedure should be the person who takes consent.
Yeah, can you hear me? Can you hear me?
Can we have that microphone on, please?
Yeah, the issue we face in radiology is that we're receiving requests from multiple referrers. So the logistics of, because we don't have clinics, if it's an elective procedure, for example, for fibroid embolisation, you can clerk the patient, discuss it in your clinic. But for inpatients, it's logistically, I would say, impossible to go around to every ward and speak to all of your patients and deliver the service in a timely way. So I think the guidance is that if you can delegate to an appropriately trained professional to do the first part of the consent, is the practice that we use. So what we do is we provide we provide leaflets and advice and also training for junior doctors in interventional procedures so that they have an understanding of what it involves and are happy and comfortable with providing that first part of the consent.
In that consent process, should they be consenting for death?
We do routinely consent patients for death in nephrostomy. I've got the statistics which I can put on the app of what we do in Leicester, but I think, they have to be aware of all the risks. So actually, a lot of the interventional procedures I do have death. For example, the PTCs have death as one of the complications. But we also give the probability of that. So we don't just say it. Yeah. We give the statistics about how frequently that occurs.
Thank you. So, Jake, why don't urologists stick in nephrostomy tubes? If they did, what effect might that have on the choice between JJ stenting and nephrostomy? I'm summarising about 7 questions here, by the way. And would it help you in planning your next step as well, if the urologist did it?
I think fundamentally in the UK, it's an issue of training. I think there may well be countries worldwide where urologists do put in nephrostomies, and we may be seen in the UK as lacking in not being able to deliver that service. But I think we are trained to expert level in what we do, and working as part of a team, I think, is fundamental. I think if you could do your own nephrostomy access, if you can do your own PCNL access, then there's no reason why you shouldn't perhaps put your own nephrostomies in. But it's about doing it regularly enough to have the best outcomes and do it safely. And I'd make the same argument with reference to PERC access. And I think I'm very well supported by an expert team of interventional uroradiologists who gain my PERC access. And it's not just a matter of getting into the kidney, it's getting into the kidney in a useful place. Our radiologists work with us in an MDT setting to achieve that. And I think they also think about this when it comes to the acutely obstructed system. So they're putting nephrostomies in potentially with a view to an antegrade ureteroscopy rather than just putting them in where they can. So I think it's an impossible one to answer in the current training system in the UK. Perhaps there's scope to involve nephrostomy insertion longer term in UK training, but the way things are going, I don't think so. And I think the key is adequate teamwork, good communication, as colleagues have said, and working forward in the patient's best interest.
I've got a question for the audience. How many people do put in their own nephrostomies? Okay, so, yeah. A minority, yeah, a minority. So, Mervyn and Anthony, really. So, if we've got infection causing an altered immune response, and that's really what's making the patient ill, is immune modulation the next step?
Please do.
Okay. The answer is yes, but we've got to be a lot smarter, because at the moment, measuring immune suppression at the bedside ain't easy. There are point-of-care devices coming through that hopefully in the next 5 years or so we'll be able to say, yep, this guy's immunosuppressed. And there's actually research going on at the moment looking at immunostimulants. So anti-PD-1, PD-1 inhibitors that are used for cancer, they've been used to boost immune function in septic patients, interleukin-7, interferon gamma. So again, you wouldn't want to give these to inflamed, pro-inflammatory, hyper-inflammatory patients, but in the right immunosuppressed patient, it could be a great drug. But I think we need to titrate the therapy rather than just give it blindly. I think over the years, we've probably done bad to patients by giving some very good drugs to inappropriate patients. So I think, personalised medicine is key. I don't know if you want to
agree. It's the whole idea of 4P healthcare, isn't it? This concept that we're going to be able to use eventually big data to drive healthcare and make it 4P, personalised, predictive, preventative, and I'm trying to remember the last P, but you get the idea.
Have a nice P, yeah.
Of course.
We always like it when the urine's coming.
Yeah. So, Ros, there's a number of questions on pregnancy and and radiology. So things along the lines of low-dose CT has been recommended at RSM meeting recently, role of image intensifier, and also stent versus nephrostomy in pregnancy.
So going on to CT, there's been quite a lot of development for acute appendicitis in pregnancy and delaying diagnosis and avoiding doing a CT. But I think urinary tract obstruction is different, and in the first instance we can get a diagnosis of obstruction from an ultrasound with good high predictive value, and it doesn't require any ionising radiation burden. So I would advocate doing an ultrasound, decompressing the kidney, and then we can investigate, once the patient's more stable, about what the underlying cause is. And often you assume there's a stone, and then by the time you do the CT, you know, the obstruction may have passed. But I still think that actually the CT is not necessary to treat the immediate thing. So I wouldn't potentially, in this particular case, in this scenario, clinical scenario, I wouldn't advocate CT for just making the diagnosis of obstruction.
Okay. And Bruce, there are some very specific questions for you. Okay. I'm going to say whoever wants to know about the specific treatment of Candida glabrata, they should come and talk to Bruce about it. How do you want a stone given to you?
Oh, we just accept it in a conventional dry stone. I mean, essentially what we do in the laboratory is we wash it so that you get any organisms that might be on the outside of the stone. We wash them off. Obviously, it is a stone, so it will have an irregular surface. Then we break it, and then we break it and fragment it, and we put it on agar and then actually follow it up from there. I have sent the sort of recipe to colleagues of Darren's in the past. I mean, yeah, it is quite useful. I mean, one of the problems we got at the moment is about just in terms of what if there are 5 or 6 organisms, what do we do then?
Okay. And my one last question, which I think is a good one for all of you, is we've got a patient who has gone from being well to unwell, and we know about it. How quickly should we decompress? What is the maximum time? A number, please, in hours.
I think it's looking at the patient and the trajectory of decline. So if they're stable and not that bad, then I'm less fussed. But at the end of the day, you know, source control is far more important than antibiotics. So if that patient's declining, come and help. And actually, I'll praise Darren. You know, we had an unstable patient, and he actually put stents in the unit on the bed. Very slick. So I'll commend the chairman. I don't know if that's kosher or not in the urological world.
Oh, I'm quite used to it.
But it worked brilliantly, and the patient did very well afterwards. So yeah, even if you have an unstable patient, if you don't get the source out, you've got a problem.
From the radiologist perspective, I think if they're infected, obstructed, and they've got a stone, I would consider that as a radiology emergency. So I think we should do that promptly, really.
I think I would just highlight that sometimes patients are sick, but that they're not too sick to go and have the procedure. And I think we need to not worry so much about that and get on and do the thing that's going to make them better. By means of an example, we had a patient on our unit with necrotizing pancreatitis and a collection who came on high-dose noradrenaline, was in ARDS. They popped a drain in. And I know it's a different condition, but within 48 hours, he was off the ventilator, off the noradrenaline, and asking when he can go home.
From a urologist perspective, as soon as you pragmatically can, and as soon as the patient is in a state where you can do it.
So Darren, over to you.
So before I thank the speakers, just 2 points about activities later on this morning. The posters in room 4, I think you've just got about a few moments to have the 4th P, grab a coffee, maybe a 5th P, and then go to the P for posters. So that's happening very shortly in room 4. Then tomorrow morning in this same room, our other plenary session, Optimising Your Patient, Optimising Yourself, followed by Professor Ben Chu, who was sitting there, and now he's sitting here. He's moved around. So over from Vancouver, who's going to talk about the fate of fragments and the science of stents. But with that to look forward to, I'd just like to extend Richard and all of your huge thank you to Jake, Bruce, Anthony, Ros and Mervyn for an absolutely fantastic session. Thank you.